Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of Eversight, I would like to thank you for joining tonight's program, Eversight's Global Initiatives to Combat Corneal Blindness. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of the screen. We will address all questions at the end of the webinar. Before we get started this evening, we would like to gain a better understanding of our audience and learn a little bit more about where you're logging in from. So at this time, I would like to introduce our speakers for this evening. Colin M. Ross is Vice President of Global Development for Eversight and is passionate about promoting eye donation and cornea transplantation around the world. Over his 20-year career, Colin has been privileged to work with dedicated physicians and transplant professionals in many countries to combat corneal blindness through transplantation, research, and medical education. Most recently, he led the development of a national network for eye banking and cornea donation in Pakistan. Colin holds the Certified Eye Bank Technician credential from the Eye Bank Association of America, a Master of Public Management degree in International Security and Economic Policy from the University of Maryland, and a Bachelor of Arts degree in Political Science from Michigan State University. Eric Hellier is the Global Development Director at Eversight. He holds a bachelor's degree in biology from the University of Akron and an MBA from Indiana Wesleyan University. He has been in eye banking for more than 15 years and joined Eversight upon affiliation with the Cleveland Eye Bank in 2012. For the past 8 years, Eric has served as a member of the Eversight Global Development Team and spent 3 years in South Korea overseeing the development of Eversight's first international location in Seoul. He has also worked to help develop sustainable eye banking infrastructure in Pakistan, with facilities already opened in Islamabad and Karachi. Additionally, he has served on the Eye Bank Association of America Accreditation Board since 2012 and has been a certified eye bank technician since 2006. And at this time, I'd like to turn it over to Colin Ross.
Thank you very much, Michelle, for that very kind introduction. And thank you everyone for joining us tonight. It's a wonderful privilege for us to be able to tell you about our work here at Eversight and our global initiatives to combat corneal blindness. So I'm going to go ahead and trust that I can advance the slide here. There we go. We start, as we always do, any significant endeavor here at Eversight by reminding everyone of our mission, which is that we restore sight and prevent blindness through the healing power of donation, transplantation, and research. And this is what we're here to do in the United States and around the world. Our global programs that we're going to be telling you about tonight consist essentially of 4 main areas of work. The thing we're best known for, since it's what we've been doing consistently since we were founded in 1947, is the provision of cornea tissues for transplantation. Was and is and presumably always will be absolutely core to how we serve. Also, we're going to talk about other elements of our program, including eye bank system development, our clinical training and education program, another very important component of how we serve around the world. And we'll talk a little bit about ocular public health research and advocacy and why that's also an important part of developing effective solutions for global corneal blindness. Just to give you a sense of the scale of impact for our organization, these are some figures related to the work that we carried out in 2020 at Eversight. And keep in mind, all of this was in the context of the COVID-19 pandemic, which challenged us and many other organizations in a variety of ways. But throughout 2020, we worked with over 5,000 donors and donor families who gave the gift of sight for transplantation research and education. And we always remember and keep central in our mind that everything that we do at Eversight depends upon the generosity of our donors and donor families who make the decision to give the gift of sight at a very difficult time in their lives to help someone else see. And we'll talk about the impact of that a little bit. Thanks to the generosity of those donors and donor families, we were able to provide over 9,000 tissues in 2020 for transplantation and research. We worked with surgeons in 27 different countries. And we provided training and clinical education for 642 surgeons and other clinicians. And as Eric will be telling you about in more detail shortly, one of the reasons we were able to do this very effectively, even under the circumstances of the pandemic, was thanks to some innovations we developed for delivering clinical education resources in a virtual format. And thanks to those innovations, we were able to double our reach in clinical training and education during 2020. So we're very, very proud of that. And we're also extremely grateful to all of those who make it possible, especially our donors and donor families. I want to talk a little bit about corneal blindness as a global public health priority, why it's important. Really, the biggest single reason why this is an important global public health priority is the scale of people who are impacted by it. Depending on the statistics, and we'll talk in a little bit when we talk about public health research, there's a need for much better data, but based on, depending on what sources you look at, there's anywhere from at least 5 million to as many as 12.5 million people in the world right now suffering from untreated corneal blindness. It's one of the leading causes of blindness that can be treated and prevented. So not all blindness is preventable, but very often corneal blindness is, and so interventions for corneal blindness can be very effective from a public health standpoint. 90% of those who are affected by corneal blindness live in lower income settings, or what's referred to in the public health literature as lower and middle income countries. So this is a problem that disproportionately affects the most vulnerable. And it has a wide variety of causes related to both infectious and non-infectious conditions. And so because of that wide variety of causes, corneal blindness really covers a fairly wide swath of the ocular global public health spectrum. One of the most striking statistics with regard to corneal care that I find worldwide is this figure that 53% of the world's population has no access to corneal transplantation. So here's this very effective cure for many forms of corneal blindness, and yet more than half the people in the world have no access to it whatsoever. Very few countries in the world are self-sufficient with regard to corneal resources for corneal transplantation, particularly donor cornea tissues. In many cases, countries are able to import cornea tissues from the United States, and this is a very important short-term solution, but really in the long run, there's a need for additional capacity and infrastructure development that's lacking in many countries around the world. Just to provide some additional context about how, when we talk about cures for corneal blindness, we're talking about something that really, is for underserved communities and patients. There's such a substantial amount of untreated corneal blindness throughout the world. It disproportionately affects the most vulnerable communities and patients. Lack of donated corneas is one of the major barriers, certainly not the only major barrier, but it's one of the major barriers to access to effective cornea care. And so effective eye banking systems are necessary in order to make corneal transplantation available globally. Another important point about corneal blindness interventions as a global public health priority is quite simply that they're cost effective. It's been estimated that the total annual global cost of blindness and visual impairment is more than $400 billion. And studies have also shown that eye health interventions are quite cost effective, with studies showing that approximately $4 of economic benefit is generated from every $1 invested in ocular public health programs. So not only are effective ocular public health interventions important from a humanitarian point of view to improve people's lives, or in many settings to even save lives, in cases where there isn't the kind of social safety net to support people who are blind or severely visually impaired. But just looked at from a purely monetary standpoint, it's a very cost-effective type of public health intervention. And increasingly, the literature is showing that eye health, apart from being something that might have been thought of previously as tangential or peripheral to economic development programs, really has been shown to be necessary for improving economic conditions in the kind of communities that are disproportionately affected. So we've talked a little bit about why global corneal blindness is a significant ocular public health priority, and I've given you a little preview of some of the programs that we have at Eversight for addressing this problem. I'd like to turn the floor over at this time to my colleague Eric Hellier to talk about the first of those types of program, which is the gift of sight and the donation of cornea tissues for transplantation. Eric?
Thanks, Colin. So yeah, now I just want to talk to you a little bit about the tissue services that we offer with this idea of the donated corneas for transplantation. And then afterwards, I want to talk a little bit about our training and education that we've been able to do. So before we get too far into the tissue placement part of it, we have to talk about our fair and equitable distribution practices. So we're mandated to have these in the US, and most eye banks have something that looks very similar to this. First and foremost, we have emergency surgeries. So that's if somebody has something that's going to cause continue to cause more damage if they don't get a transplant immediately, something like a corneal melt perhaps. We would move that right to the front of the priority list for obvious reasons. Next, we go with our local scheduled surgeries. So this is a doc calling us up and saying, I have a surgery in 3 weeks. I need a PK cornea. We do all of those with all of our surgeons. Then if there's anything left over from that, we would go into our domestic needs followed by international needs. Now the somewhat, not quite unique, but a fairly unique thing about Eversight is that we have our scheduled surgeries, whether they are domestic or international, considered local. So if an international surgeon says they need a cornea in 3 weeks, that goes into that second category for our local scheduled surgeries. So these domestic and international needs would just be after we have everything that we have already scheduled filled. And finally, if there's no other opportunity to transplant the tissue, then we would put it into a long-term preservation so that we can elongate the possibility of transplanting the tissue, give us more than just the standard 2 weeks that hypothermic storage gives us. You can see this is a map generally of where we're at. So the blue circles represent where our offices are: Ann Arbor, Michigan, Chicago, Illinois, Clark, New Jersey, Cleveland, and as Colin had mentioned, Seoul, South Korea, which I'll get to that a little bit later. And you'll see where all the pins are the different countries. We have 26 countries that we provide tissue to outside of the United States. So one thing that you'll notice is although there's a lot of these pins all over the map, there's a lot more blue that doesn't have the pins. This just goes to show that no matter how robust somebody's ability to transport tissue across the borders is, it's never going to meet the local needs. There's far more need out there than all the corneas in the United States could possibly give. So one of the things that Colin did touch upon before, and I want to reinforce, is this idea of the stewardship of the gift and how precious we view this gift. This is really the heart of our mission. I'm asked several times, what is eye banking all about? And that's the only word that I can come up with: stewardship. We take something that somebody has heroically and graciously donated at one of the most terrible times of their lives. They still have that wherewithal to be a hero, give something back to the community in a tragic event. And we take that very personally, very seriously. Another way that we kind of differentiate ourselves is that our reimbursement fees are based on a number of socioeconomic factors. So we look at it as the ability for the country to pay whatever the reimbursement fee they can, so that we can offer the most range of tissue to all of the countries that are affected by corneal blindness. So obviously there's countries out there that can't afford the full fee that we can in the United States or some other higher income countries, and we want to take that into account before we just put tissue wherever we can. The tissue that we do provide for transplant is standard PK, DALC, DSAIC, DMAC, and preloaded DMAC, and we can provide that tissue all over the world. We're particularly proud of the fact that in spite of this global pandemic that hit us in 2020, we were still able to provide more than 2,000 corneas outside of the United States, which is very amazing to me. I'm still really happy with this number because we had 3 months of total shutdown in the US and more like 5 months of shutdown outside of the United States. And still, we were able to work with the surgeons, work with the eye banks, all of our valued partners, and provide this tissue so that more than 2,000 people could see by the end of 2020. That's just, it really still hits me every time I see that number when I think about all that we went through. And one of the things with COVID that we talk about is this idea of testing for COVID. It's kind of a hot topic with eye banks. Do you test? Don't you test? there's great points to be made on either side of it. With Eversight, we just felt like testing for COVID fell in line with our standards and what we want to provide the tissue. We don't use it as the only end-all be-all to determine COVID positive or COVID negative. We use it as just another data point. So with that, we take all of the medical records into account, but we also want that added extra security of that COVID test. So our practice is to have a negative COVID-19 test on all surgical corneas that we recover. Now, as we started talking about earlier, we've got our operation in Korea, and I have to say this is one of the coolest things that I have ever been involved in my life. This is the first US-owned and operated eye bank outside of the United States, and it was opened in 2015. I have had an enormous pleasure to work with the exceptional Korean staff that we have out there for 3 years. It has just been an amazing experience for me. It serves as that regional hub for surgical tissue, physician training, research support. But for us, it was so much more than that. Because what we were able to learn was taking the US system and trying to not force it into the Korean society, but rather integrate it. Take it and say, how can this work in this culture, outside of our norm, outside of our comfort zone, and really work together to make this something wholly unique. And that's exactly what I feel like we did. And we continue to do. As the rules change, as laws change, as things become more fluid there, we're able to adapt and work with the local surgeons, work with the local regulatory agencies, and create something that is really very unique and something I am very proud of. So I want to talk a little bit about the training and education that we've been able to provide around the world. Clinical training is one of the biggest things that we do. You can see that in, like, these webinars are an example of some of the clinical training that we do, passing ideas along, skills transfer. But wet labs are really the bread and butter of these kinds of things. We do some on-site training. We develop the eye bank practices, surgical techniques. But these wet labs are really a great way to get to know people, really get on the ground, let them see what Eversight is about, and let us see what they're about, what's going on in their world, how their patients are affected by everything. I think I can speak for everyone in this department when I say, when we do these training sessions, we learn as much as we teach. I mean, without question. Now, COVID created a particularly challenging scenario. I think we can all say that. But we wanted to maintain that community presence. We wanted to take the efforts that we had been making and the strides that we had been making to teach and help transfer all these skills that we had and work with people around the world. And we didn't want it to go away. But how do you do that? We've been used to just going into places, being in there, holding these live wet labs, being able to hold training sessions. And we can't do that, obviously, because everything's shut down. So this is where we pioneered these adaptations to this wet lab. We had already had these surgical practice systems in place designed for training and education, where you can order these kits, and then they come and it has basically everything you need minus the operating microscope to be able to practice the surgery. Well, then we started thinking, all we really need is some way to have a Zoom meeting or some way to communicate, to show what they're seeing in the microscope. And that came about when we were working with one of our medical directors. He had proposed this very inexpensive, highly efficient system that's a camera adapter, where you can take any cell phone, put it onto this, and then attach it to the teaching microscope on the operating microscope. And that was the final piece we needed. Now, through Zoom, you can see what the attendee is seeing. The surgeon that's across the world, perhaps, a US surgeon and a Malaysian attendee are able to communicate and do an unscrolling technique for DMAC. But now we can see that. And the interesting thing about it is that in some ways, these virtual wet labs have become even more efficient than the in-person ones. Now, I don't think that they'll ever take the place truly of that skill transfer, but one of the unique things about it is that the surgeon can see 3 different microscopes simultaneously. So you're teaching 3 people, and the attendees can also watch the other attendees through their laptop. So now you've got highly skilled surgeons training, but you've also got attendees watching other attendees going through some struggles and being able to learn from that. So it's a very effective teaching tool. The mission trips are another piece that's very deep and dear to us. We do provide tissue for mission trips and we'll work with the surgeons on these educations and skill transfers. Now, in spite of, again, being shut down in 2020 for most of the year, we were still able to have an impact in Vietnam, the Philippines, and some other countries with these mission trips. So we still were able to get somewhere and have people benefit from this, surgeons benefit, patients benefit from it, eye bankers benefit from all of these skills transfers in spite of this, this pandemic really hampering us. And we're also adapting in these virtual learning. Now, we are working with other organizations to try and get teaching up and running, not just from, similar to what we're doing with the webinars, but not just from a skills transfer and a hands-on or the wet lab transfers, but really start educational opportunities in a virtual environment. We feel like while things will go back to some semblance of normal and we will still have in-person opportunities, and I've been a kind of person that feels like nothing will ever replace looking somebody in the eye and shaking their hand. But these virtual opportunities are here to stay. And it is a wonderful opportunity to have a bunch of people that otherwise can't travel, learn and be taught different things, way to just spread your knowledge and actually take in more knowledge from across the world. So finally, I wanted to talk about some of the support that we have for the surgeons. There's this webinar series, which eversightvision.org/webinars. We already have a good library built over the last several months. Go and check it out. There's some really good stuff there. I'm sure everyone will find something they like. We can do on-demand training, as we've talked about, in all of these different opportunities. As I brushed on the SPS kits, which I think are a fantastic way to keep skill set up. You don't even necessarily need the surgeon to teach you how to do it. If you've already done it once or twice, you can still order the kits from us and some training tissue and practice yourself. And then again, these wet labs. So in addition to the virtual wet labs and in-person ones, we've also done fully didactic wet labs, which come in somewhat of a hybrid between a wet lab and a webinar. And we found a lot of success with those as well. So with that, I'm going to turn everything back over to Colin. And
all right. Thank you, Eric. Very proud of you and our team for all the work that you've all done throughout this very difficult year, but still producing wonderful impact for our patients and everyone that we serve. I want to talk about the third element of our global development program, which is our eye bank development program. So as we talked about earlier, there's a real need for significant capacity building in a variety of places around the world. And this is one of the programs that we have to help meet that need. When we engage in eye bank development programs, we do this according to a number of principles. So for one thing, we always want to build systems that use the absolute highest clinical standards based on international best practices. So we don't want to reinvent the wheel. We want to take the well-known body of clinical knowledge in eye banking that's already there from the United States and from other countries and build upon that and adapt it to the settings in which we are working to build systems. One very, very important part of that also is to develop and implement culturally appropriate donation models. Because eye banking is not just a medical service, not just a clinical service, it's a public health service, and it depends very, very critically on trust and relationships within the community. So there's a very, very strong cultural component to building successful donation systems. And so we put a lot of focus on building culturally appropriate donation models. And this is really an area where we, as the outside quote unquote experts, do not come into a situation and tell people what to do. We come into a situation and first and foremost, we listen, because we need to be able to understand what's important to the communities in which we're working, and to be able to kind of take on and understand the appropriate cultural framing for everything we do, because it's absolutely critical for the success of donation programs that they be tailored to the culture in which they're going to be operating. Obviously, we always endeavor to adhere to the absolute highest ethical standards. We help to develop an international standard ethical framework called the Barcelona Principles. We're very proud to be one of the contributors to that document. And this sets a very, very high ethical standard for all international activity when it comes to cornea donation and transplantation, and had input from all sorts of leading institutions across the entire spectrum of the cornea transplantation community globally. And so both ourselves and our partner organizations, we hold ourselves to the absolute highest ethical standards as embodied in the Barcelona Principles. Stakeholder relationships are absolutely critically important because, again, the eye bank is not just a clinical or medical service. It's really a network of relationships. And in order for an eye banking program to be successful, it requires very solid relationships based on mutual respect and trust, not only across the medical and transplant fields, but also with other types of stakeholders, including government officials, community leaders, religious leaders. Very, very important stakeholder relationships there, because again, that goes along with having culturally appropriate donation models. The religious context is often a very, very important part of that. Media, for example, also important stakeholders. We work with Lions Clubs as part of our community efforts. We saw in the United States, our experience over the past several decades has been that community leaders and community organizations like Lions Clubs are absolutely critical in building support for donation among the public. And so those kind of stakeholder relationships are very critical for us to develop. We seek to maximize local capacity development through knowledge transfer. This is a very important point, that we don't want to build systems that are dependent upon continual intervention from the United States or from outside. We really want to develop systems that are able to function autonomously, able to grow, to build upon their own successes. And we do that through knowledge transfer, including some of the training and education programs that Eric talked about. And even though in eye banking, we tend not to be big money people, we're really more focused on mission. We do, when we're developing systems, we absolutely have to consider sustainable financing and management in order for those programs to be able to be sustainable over time. And so we work with our partner organizations on those elements as well. So these are kind of some overarching principles, but I want to talk through a specific example of one of our major eye bank development programs, which is our program in Pakistan. This is the largest eye bank development program that we've done to date, and I'm very, very pleased to be able to share some information about it with you. So we have our work in Pakistan, we have carried out through kind of a loose affiliation that we have called the Pakistan Eye Bank Network, or PEBN. Some of the questions that we get asked are, why Pakistan? Why did we decide to make it a priority to work in Pakistan? One of the major answers to that question has to do, again, with the scale of need. Right now, there are over 250,000 patients in Pakistan who need a cornea transplant and can't get one. Corneal blindness is the second leading cause of preventable blindness in Pakistan after cataracts, and there are a variety of genetic and environmental causes that lead to that high incidence of corneal blindness in that society, many of which are exacerbated by the effects of poverty. Historically, there have been almost no local donations of cornea tissues in Pakistan, and so Pakistan has had to rely on imports of cornea tissues from the United States and from Sri Lanka, and these are very often expensive and in too short a supply. So working with our partner organizations in the PEBN, all of whom are very well-known and trusted charitable eye care institutions within Pakistan, we developed a program that has several critical elements to it, starting with the development of a common set of medical standards based on the US standards as embodied by the Eye Bank Association of America, but adapted for use in Pakistan. So adapted to the local healthcare system, in particular, and this provides that high level of clinical standards based on international best practices, and it's common across all of the member eye banks of the Pakistan Eye Bank Network. So it provides a common, well-controlled, clinical standard for the entire network. From that, we developed a set of standard operating procedures. So these are the policies and procedures that govern the specific clinical activities that take place within all of these eye banks. And these can be adapted by the local eye bank as necessary to meet their their local needs in terms of staffing, training, things like that, but always based upon and derived from this common set of medical standards. So based on these international best practices adapted to the local environment. Training was an absolutely critically important element of the PEBN program. This includes training for the iBank staff members and also for the cornea physicians, particularly those who would then go on to serve as medical directors of the member iBanks of the Pakistan iBank network. We worked with the member iBanks on facility design to develop facilities that are up to the highest international standards. If you were to walk into one of the PEBN iBanks in Pakistan, that would be at the highest standard of any iBank in the world. So we were very, very proud and pleased to be able to assist with that. Equipment and supply sourcing. This is something that's important to the success of an iBanking program. And in a setting like Pakistan, sometimes the requirements have to be adapted. Some things that we take for granted of being able to obtain in the United States might not be obtainable in other countries. And so this is an area where again, we adapt and still able to do everything at the highest level of excellence, but adapted to the local realities as well. Ethical standards as well, again, based upon the Barcelona principles, that's a key element of the PEBN program. And then last but absolutely not least is the donation program development, which is probably the most important single element of the entire thing. You can have the greatest facility in the world, you can have the best trained people in the world, you can have the best set of medical standards and SOPs, but if you don't have donors, then you don't have a functioning iBank. And so that donation program is probably the most critical element. It depends vitally on developing those culturally appropriate models. It depends vitally on those stakeholder relationships that we talked about. And so this has been a key element of our program in Pakistan. So implementing a program, as we have for the last few years, I believe we first kicked off the program in 2016. And we've had a lot of progress, particularly over the last couple of years as the initial programs that we began developing there have come online. We've been slowed down somewhat by the COVID-19 pandemic, so our activities in Pakistan in 2020 have had to be sort of rearranged. Some of the priorities and scheduling of things have had to be rearranged into 2021 and 2022, but we're still very proud of the progress that we've been able to make to date. So far we have seen the iBank laboratory facilities and donation programs be implemented with our partner Al Shifa Trust Hospital in Rawalpindi and with our partner, the Pakistan iBank Society in Karachi, two of the major metropolitan areas in Pakistan. These include pilot donation programs that have been developed with local charitable and public hospitals. So these are based on what they call the Hospital Corneal Retrieval Program model, which was used very successfully for decades in the United States and is currently in use successfully in other countries within the region and elsewhere around the world. So these types of donation programs have already begun being implemented within these local charitable and public hospitals on a pilot basis with some success so far that we're very proud of. We have seen the launch by our partners of the initial donation awareness campaigns within their communities. So these include television pieces that have been very impactful, in some cases nationwide coverage. Social media campaigns, which have been very effective, engagement with political leaders, engagement with media figures and other types of celebrities to build support for donation in a society where this has not been a common thing to really be talked about up to this point. But our partners have been working very successfully to build the profile of cornea donation and transplantation through their awareness campaigns. Looking ahead, we are expecting to launch the iBank facilities and programs in the cities of Lahore and Peshawar, two of the other major metropolitan areas within Pakistan. By 2022, that will be somewhat dependent on the COVID-19 situation, both in the US and in Pakistan. So for example, Pakistan is currently experiencing a surge in COVID-19 cases based on what our partner organizations are telling us. Situation here in the US is still fluid, so we're having to remain flexible with regard to our timeline. We have 2 eye banks up in operation currently. We're expecting to bring 2 more online within the next year or so, depending on COVID. And we have very exciting plans for future phases of our programs in Pakistan, and the planning for those phases is underway currently. And again, implementation will be subject to a variety of factors, including the COVID situation. So along with the development of the eye banking clinical programs, as I mentioned, our partner organizations have been forging ahead with the implementation of their donation programs. So not only awareness, but actually direct engagement with the community to get people to register and to sign up to be eye tissue and cornea donors. And this you can see as an example on the left there of programs that our partner organizations have carried out with various public constituencies. And also you can see an example there of the kind of donation form that's in use by our partner organization in Karachi. So we've been very, very proud of the progress that our partner organizations are making in this. And this again is an area where this is not something we run. This is something that we helped provide a spark. We helped provide encouragement. We shared the knowledge that we had, and our partner organizations are taking it and running with it, and we could not be prouder of them. I want to show you, this is one of the more interesting experiences that I've had in doing this kind of work. This was the inauguration of the first eye bank that opened under our PEBN program. And this was the inauguration of the eye bank at Al Shifa Trust Hospital in Rawalpindi, which took place in May of 2019. That gentleman who's there front and center in the sort of white and dark blue is Dr. Arif Alvi, who is the president of the Islamic Republic of Pakistan. So it's the first time, to my knowledge, that the president of a country has inaugurated an eye banking program. And this was something that garnered nationwide television coverage and news coverage in Pakistan, something that's very, very proud to be associated with. I should point out also that all of this work that we have been doing in Pakistan has been supported to this point by a generous donation from the Qazi Family Foundation. Mr. Muhammad Ashraf Qazi here in Michigan provided very generous support for our programs in Pakistan to date. And you can see in the upper right, the Pakistan Eye Bank Network logo, and the subtext there is also thanking the Qazi Family Foundation. And this is a photo from the eye bank inauguration in Karachi. And the lady in the foreground on the left side is the health minister for Sindh province, which is the province in which Karachi is located. It's one of the major provinces of Pakistan. And this again garnered major media attention. The minister not only inaugurated the eye banking program, she appeared on local television and local media supporting donation, and actually took a stack of donation forms with her and intended to encourage the other members of the provincial parliament as well to sign up and show their support also for cornea donations. So it just shows the importance of leadership and of these stakeholder relationships. So that's one example, one major example of our eye bank development programs and the kind of impact that they can have from our work in Pakistan. I want to talk about kind of last but not least, the fourth element of our global development program, which is in the area of ocular public health research. So as I mentioned, there's a wide array of statistics related to the prevalence of corneal blindness worldwide. This points to the need for better data on global corneal blindness than what is currently available. The current instruments that are used in the public health field to measure various types of blindness worldwide tend to undercount corneal blindness. And it's very important that we develop better data on this so that we can better assess needs of different countries and different communities, so that we can raise awareness of corneal blindness as a global public health priority, and so that we can better target our interventions to be as effective as possible. But with the data that we have available, we know enough to know that the magnitude of corneal blindness is similar to that of diabetic retinopathy and glaucoma, although both of those are much better covered currently in the global public health literature. So that's why we focus our efforts on improving the quality and availability of research in the cornea field in particular. And to do this, we partner with a variety of other organizations to develop studies and implement public health research to try to close the gaps that we've identified in our knowledge of global corneal blindness. So that's a little bit about us and what we do, the kind of impact that it has, why it's important. What can you do? Well, I would say if you are an international physician or a physician who has interests in mission trips or other types of involvement internationally, absolutely reach out to Eversight if you require cornea tissues for international use. As Eric mentioned, we provide tissues for mission trips, and we routinely provide corneas in many countries worldwide. So if you're in that category, absolutely reach out to us. We would love to be able to help. As we mentioned, that's absolutely core to what we do. Also, we invite you to collaborate with us in our clinical training and eye bank development programs. You know, as we mentioned, these types of programs depend on a variety of stakeholders. And so we're very, very happy to have collaboration from people in many sectors across the cornea and public health fields to help us make these programs happen and to make them as impactful as they can possibly be. And then obviously financial contributions make our work possible. All of the work that we do globally is supported through financial contributions from our stakeholders. Financial contributions at any level are always welcome. Eversight is a 501c3 nonprofit organization, and we would welcome any support in that area as well. And with that, I would just like to say thank you. I would like to encourage you to reach out to Eric and myself or our colleagues at Eversight at any time. Michelle, I believe we have, we'll move to question and answer.
Yes, as noted earlier, if you do have a question, you can type it into the Q&A panel.
Yeah, we'd be very happy to answer any questions you may have. And again, really appreciate everyone sticking with us, everyone attending tonight.
First question we have is, in what way do you partner with Lions clubs internationally on eye bank projects?
Yeah, so that's a good question. So as I mentioned, in the United States, Lions have been critical to the development of eye banking. Eye banking would not have been successful in the United States were it not for Lions clubs. Lions clubs provided the financial support, they provided the governance and direction, and they worked within their local communities to build support for donation, which when you think about a setting like Pakistan, where donation has not been a common topic of public conversation up until now, it was the same in the United States in the 1950s. It was not a mainstream concept. It was not something people really considered strongly, and it was Lions clubs that made it a mainstream concept. And so when we look to partnership with Lions clubs in other countries, we look to them for the same kind of role. Their financial support is critical to getting these kind of programs off the ground. But even more important than that is they are, everywhere you go, Lions are trusted leaders within their community. Whether they're from the business world, the social services world, whatever background the Lions have, they are trusted people within their communities. And so they are perfect ambassadors to bring this message forward. So for example, one of the examples at the top of my mind is the Lions clubs in Lahore, Pakistan. We had an amazing experience getting to know the local Lions there and working with them to, on plans to build support for that eye banking program, including, potentially, depending on how the program shapes up, could end up looking very, very much like it did in the United States with a governance role and that kind of thing. Peshawar as well, another place where there are Lions actively engaged in and ready to support that eye banking program as it gets off the ground. So I guess the short answer is the way we think of our engagement with Lions outside the United States is very similar to the way we have always engaged with Lions here in the United States. And really, to put it extremely simplistically, a lot of other countries need the Lions to do for them what Lions have done for the United States since the 1940s and 50s.
Okay, next question is, are the corneal diseases being treated internationally significantly different than corneal diseases being treated in the US?
They vary a little bit, and I'm not sure how much of our audience is physician versus non-physician, so I'll try not to get super technical. I'm not a physician myself, obviously. I have a degree in political science, not biology like Eric. But really, I think the key difference that we see, or some of the key differences we see, are the patterns of endothelial disease are different outside the United States. There isn't much Fuchs dystrophy, for example, outside of North America and Europe. It's much less common. However, we do see pseudophakic bullous keratopathy is probably, it's the leading cause of endothelial dysfunction from what we've seen outside the United States, and that has to do with cataract surgeries mostly, and how those are sometimes performed outside the United States. So so that's one thing. And then we also see keratoconus and other types of inherited dystrophies can often have increased prevalence outside the United States due to genetic factors. We also see sometimes environmental factors can affect the patterns of what we see in terms of things like traumatic injury, things like infections, fungal infections, that sort of thing. Eric, is that, is there anything to add there?
No, I totally agree. And one of the other points that I wanted to make, I'm glad you put fungal infections at the very end, because we've seen issues where there are certain things that we take for granted in the United States and in other countries. Clean water is an amazing example of that, where we will see an increase in fungal infections, but it's not necessarily because of any reason other than the environmental factors that are surrounding them. So in that way, yeah, they definitely are treated differently. I would also say that when we talk about treating them differently, the availability of education and practice are another main consideration with this. So while there might be, you might have a patient in a country that they have textbook Fuchs, the surgeons might not be trained to do a DMEC surgery. So yeah, they have to treat it with a PK because they don't really have the access to education or opportunity otherwise.
Well, and this gets to another important factor as well, which is late presentation, due to various barriers to access to standards of care that we might take for granted in more developed countries. Those barriers are often more prevalent in less developed countries. And so you'll have patients presenting later than they otherwise would. So perhaps a type of intervention that might be available to a patient with earlier presentation might not be available to a patient who presents later. So as Eric mentioned, there might be situations in which a PK surgery might have to be performed on a patient who maybe could have been treated with DMEC, for example, or with some other type of intervention had they presented earlier.
Okay, next question is, do you have an estimate on how many corneas have been recovered in Pakistan to date?
So right now, we are, we're still in the COVID-19 pandemic. So these programs were just getting off the ground when the COVID-19 pandemic had hit. So the recovery programs had those pilot programs had just been put into place. So we actually had the first ever local cornea donor that was recovered under our program in Pakistan was actually just recovered a couple of months ago by our partner organization at Al Shifa Trust Hospital in Rawalpindi. And that was an amazing situation in which everything had to go exactly right in order for that case to be concluded successfully under those circumstances, and it was. We were incredibly proud of everyone involved in that and the way they carried out that donation opportunity. And so they're working now to build on that success. That's one of the reasons why they're really focusing on their awareness campaigns, is to try to build on that. So it's really hard to judge by the numbers right now because it was just getting started and then we got hit with this pandemic. So we would expect that we'll be able to get a much better sense of that impact kind of quantitatively as we move into move through the COVID situation and into 2022 and beyond.
Next question, other than the virtual wet labs, have you created any other new opportunities to continue your efforts globally despite the pandemic?
Yeah, we're really working our best to get back in the game to the best of our ability through these virtual experiences. One thing I'll say is that Zoom has been an amazing tool, and I think everyone on this call can attest to that. I sometimes wonder if COVID-19 was actually a conspiracy theory between Zoom and the hand sanitizer people, but neither here nor there. Maybe the toilet paper manufacturers as well in the early days. So we've been able to use these platforms for a number of different things. We're currently working with working through a couple different opportunities, as I had mentioned a little bit before, on training. So these webinars are a prime example. We're looking to partner with other organizations and bring skills transfers. We're working with a couple of our medical directors currently to look back, and we've got a lot of medical directors that have family history in other countries, and they're working to try and help out those countries even during these times with a number of different things. And you can do consults now in ways that you couldn't before. And I think
I'm sorry, I was going to just pick up on that we're really looking at telemedicine solutions that build on the capabilities that we've already had to extend the training, the knowledge transfer, and then also, as Eric was mentioning, consultations, the ability to make expert advice much more widely available through these telepresence tools. The cornea subspecialty has somewhat lagged behind, I think, some of the other subspecialties in ophthalmology in terms of application of telemedicine. But things seem to be moving in the direction where that's going to become a more important part of what we and our partners do, even once we move beyond the COVID situation.
Yeah, and I think you can actually reach a lot more people this way. I mean, I think we were kind of thrust into this virtual world in a way that nobody would have even, I think 2 years ago, we would have laughed at the idea. And certainly 10 years ago, the technology didn't exist. So if this pandemic had hit us, I don't know, in the late the beginning part of the 21st century, it would have been a much, much worse situation. So yeah, it's here to stay in some fashion or another. And I think we're trying to maintain, just sort of stay on that edge.
We're working toward a model as well of a hybrid in-person and virtual training experience that we're actually expecting to start doing some of these programs by the end of 2021, where we have some in-person instruction and support from both physicians and trained eye bank professionals, who can add a lot of value being in the room, but then also leveraging all the value you get that Eric mentioned from having world-class experts available via telepresence who can actually do this more efficiently in some cases than they can in the in-person setting. So there are ways to get the best of both worlds, from this situation while also making it more available.
Another question, surgery volume has picked back up in the US since the pandemic began. Has the same happened in the international locations where Eversight provides tissue, or is the pandemic still affecting surgery volume?
It was slower to get going again outside the United States. As Eric mentioned, we saw a 3-month drop off in the US approximately, and outside the United States, it was more like 5 months. So one characteristic of it is that it was the trough was more prolonged in terms of international surgeries. And then the other characteristic of it, I think, is that it's more kind of patchwork because the situation is different in different countries depending on how they were impacted by the pandemic. So for example, in Korea, cornea surgeries never stopped. We provided the same service throughout the pandemic that we always had pre-pandemic, and it's not like they weren't having to adapt and do things differently because of COVID, but that just wasn't one of the effects of it. Whereas, for example, in Pakistan or some of the other countries, we really did see a prolonged, drop off in surgeries that they were able to do. Eric, did you want to?
Yeah, I was going to say one of the things that I found to be particularly interesting was once things came back online, man, they came back online in a hurry. People, for the most part, surgeons made up for the volume that they lost during that downtime. I mean, internationally, we didn't quite make up, but only having 7 out of 12 months available to you, it came pretty darn close. And domestically, I think most surgeons did end up making up for lost time with that 3 months down and 9 months, 6 months after that of being able to catch back up. So that was really interesting. That was that was challenging from a supply and demand standpoint too, because we didn't have any more corneas available. In fact, we had less because of the pandemic, and yet still these surgery numbers are ramping up to catch up for what they missed. And it was an interesting last 5 months. You know, basically from August on, things got really, really quite, I don't know. It was a challenge. It was fun to see how this all played out.
And then just one last question, gentlemen, and I think you may have touched on this briefly, but how long does it take to actually build a donation program? And have there been any donors yet in Pakistan?
Yeah, so the short answer is decades. It's a long-term process. It's not something that happens quick. It's one of the reasons why there are not many organizations that have engaged in this kind of work. And it's sort of, we think of it as not for the faint of heart, and it's not for those who are not willing to make a long-term commitment to this kind of work. In the United States, the first eye bank was opened in 1944. The United States did not become self-sufficient for cornea tissues until about the early 1990s or so. So it took almost 50 years in the United States to become self-sufficient. When you look at a setting like Pakistan that's at the very beginning of this journey, there's a lot of advantages there in terms of levels of education, the ability to have assistance from other agencies to share international best practices, things like that. There are some advantages there that the United States maybe didn't have in 1944, but still it might take 20 years, for example, to achieve self-sufficiency. So it is a absolutely long-term process, but you have to start somewhere, and having started, you have to stick with it. And so then in terms of local donations in Pakistan, as I mentioned, yes, we were very, very happy just in the last couple months to see our first local donation case happen even within the COVID. We were not expecting any, because the COVID situation was so taxing to the healthcare infrastructure in a variety of ways. So we see that as a little bright spot, a point that tells us, yeah, this is going to work. We'll get through this COVID situation, and I think we'll start seeing more of the fruits of the work that's gone in there so far.
And I would just add that 20 years Colin's talking about, that's under ideal circumstances. There's plenty of countries that have been at this for 30, 40 years, and they're still not self-sufficient. It's just a matter of getting the right people on board, the right times. You got to be very determined and a little lucky. Yeah.
And it points out the need for partners to do this kind of work. It's very much needed, but it's hard. And so, it's really important that we have, partners to work with us to do this kind of work.
Well, they are very lucky to have both of you as well. So it looks like we are at the end of Q&A. There are no further questions, and we're just coming up on the hour. So I would like to thank everyone again for joining us today. The webinar has been recorded and will be available on our website for you to view on demand. A very special thank you to Colin and Eric for serving as today's speakers and for providing us with your invaluable expertise on this subject. So have a wonderful evening, everyone. Thank you.
Thank you,
everyone.